Here's an example of an extracapsular cataract extraction that was done by Dr. Calder in the late 80s. You can see at this point we would bend our own cystotomes. This is a 27 gauge needle, and Dr. Calder is bending it himself to allow him to do the capsulorhexis. These are Bellotti scissors, which are sharp Westcotts that he's using to perform the peritomy, which is done with a cord length of about 11 or 12 millimeters. Now he's using the gill knife to clean up some residual episcleral and conjunctival tissue. Bipolar electrocautery is used to achieve hemostasis. Remember that it's important to have a spark gap for that to work. 75 blade is used to make an initial opening into the eye that will allow a can opener capsulorhexis. Here you can see he's going all the way across with the cystotome, and it's a little difficult to see here. Actually, that was Helon, but here he's going across with the cystotome. You can see he's making the can opener move where you enter and then go over to where you entered before, and you do this around 360 degrees. Now with Kelman forceps, he's grabbing the capsule and pulling it free and pulling it out with all the perforations that were made with the can opener. Now with the cystotome, he's rocking the lens free. No hydrodissection is done. With Dr. Calder's extracap technique, he's rocking the lens free, and the last motion is to put the lens up and rock it up such that it's ready to come out through the wound. Now this small little section that was opened up for the rocking of the lens and for the capsulorhexis is extended using what are called Castro Viejo scissors. And here's Castro Viejo scissors are used going in one direction. Here a safety suture is placed using 7/0 Vicryl. And this safety suture would allow you to quickly close the eye should you have a choroidal hemorrhage. Now you can see the muscle hook is used 180 degrees across from the wound, and a 0.2 forceps is used to push the posterior aspect of the wound more posterior and allows expression of this dense nucleus. Now the residual cortical material is removed after closing this one safety suture. A couple of additional 7/0 Vicryl sutures are placed to allow closure of the eye during the irrigation aspiration. Here, irrigation aspiration is used to remove residual cortical material. You can see how the pupil came down following expression of the nucleus, which was not uncommon when performing an extracap. So the pupil got a little bit bigger during this, probably because of the epinephrine in the fluid, but the residual cortical material was removed. It's tricky to do the cortical material with the extracap because you don't have a nicely defined anterior capsular edge. You have a bunch of little tags left over when you do the can opener. Here you can see Dr. Calder's doing this two-handed technique, which is very difficult. He had such excellent hands, but it's very hard to do this. But he's using the Kugelin hook to expose some subincisional material here. This is an olive tip polisher. I sometimes call this the Johnson polisher after Dr. Tim Johnson, who uses this. Now we're just making sure that the sutures are out of the way and that there's no material in the wound. Some viscoelastic is placed, probably a cohesive viscoelastic like Helon is placed in the capsular bag. This is an SK21 lens, which is an interesting PMMA lens that Dr. Calder liked, that has haptics which are made of proline. And so this is a lens which he commonly used. I still see a lot of patients that have had this lens placed that are very happy with nicely centered lenses. The lens has 4 positioning holes which were useful to get the lens in just the right position. Unfortunately, the positioning holes sometimes would get in the way if the lens decentered. So positioning holes are sort of out of vogue now. See, Dr. Coulter is again using a two-handed technique to gently place this into the capsular bag. Now he's using these two hooks. And with the two hooks, you can dial this lens, and this takes a lot of coordination to use the two hooks like this, but he would dial the lens in an attempt to get the haptics into the bag. One of the things that was hard with the Extracap was to get both haptics into the bag because, again, the anterior capsule was not very well defined. Here Dr. Coulter does this nice closure with a running 10-0. Some residual viscoelastic material is removed, and then this 10-0 running nylon suture is closed. So a beautiful example of an Extracap that was planned.